আমি জ্যোতি ভাৰতীৰ তৰফৰ পৰা সকলোকে স্বাগতম জনাইছো আৰু আপোনালোকক জনাবলৈ পাই অতি আনন্দিত যে আমি জ্যোতি ভাৰতী আলোকধাম এটি শিক্ষা আৰু সামাজিক ক্ষেত্ৰত কাম কৰি থকা এটি অনুষ্ঠান আৰু এই অনুষ্ঠানৰ তৰফৰ পৰা আমি বৰ্তমানৰ পৰিস্থিতিত বিভিন্ন ধৰণৰ বক্তৃতা অনুষ্ঠানৰ আয়োজন কৰি আছো অসমীয়া ভাষা সাহিত্য সম্পৰ্কত আলোচনা কৰাৰ উপৰিও আজিৰ বৰ্তমান পৰিস্থিতিত যি পেণ্ডেমিক সিচুৱেশ্যন এই সিচুৱেশ্যনৰ ওপৰতো আমি এটা বক্তৃতা মালাৰ আয়োজন কৰিছো গতিকে সেই হিচাপে যোৱাকালি আমাৰ প্ৰথমটো বক্তৃতা অনুষ্ঠিত হৈছে আৰু আপোনালোক সকলোৱে সহযোগিতা কৰিছে সকলোকে আমি ধন্যবাদ জ্ঞাপন কৰিছো আৰু আজি আমাৰ মাজত এই ক্ষেত্ৰৰ এজন বিশেষজ্ঞ ব্যক্তি শ্ৰদ্ধেয় সত্যজিৎ ৰথ ডাঙৰীয়া উপস্থিত আছে গতিকে তেখেতক আমি আমাৰ এই অনুষ্ঠানলৈ স্বাগতম জনাইছো আৰু আপোনালোক সকলোকে এই অনুষ্ঠান উপভোগ কৰিবৰ বাবে এই বক্তৃতা উপভোগ কৰিবৰ বাবে আমাৰ তৰফৰ পৰা আমি অনুৰোধ জনাইছো আৰু আপোনালোকে আমাক এনেধৰণে সহযোগিতা আগবঢ়াৰ বাবে আপোনালোকক ধন্যবাদ জ্ঞাপন কৰিছো I on behalf of Jyoti Bharati Alokdham welcome you all to this lecture series and yesterday we have started this lecture series and the series was inaugurated by the Honorable Vice Chancellor of Guwahati University and today Mr. Satyajit Rath will deliver a very important speech on present pandemic situation. So on behalf of Jyoti Bharati Alokdham, I welcome Satyajit to this lecture series and we hope that all the participants will enjoy your lecture. Thank you, sir. And now I like to request our organizer Sandipan to introduce our guest to our audience. Sandipan.
Thank you, sir. I welcome all of you to this lecture series and whoever were present yesterday and today as well. And I welcome Professor Satyajit Rath. He is currently an adjunct faculty at IISER Pune, Indian Institute of Science, Education and Research. And previously he was associated with NII Delhi, National Institute of Immunology. Satyajit is a well-known immunologist of this country, and nowadays, if you just go to Google and type his name, many of his statements, important suggestions on coping up of the pandemic, and especially in the Indian scenario, you will have numerous of his comments and also suggestions. For his academic credentials, he has lots of publication and he is a specialist in infectious disease and immunological studies. Satyajit is also associated with science awareness and the science movement of this country. He is associated with many other such movements in this country. And he's a well-known immunologist, nothing to say new about that. He's also associated with literature and more of poetry that I have come to know very lately. Now I welcome Professor Satyajit Rath and I won't take much time and I straightforward hand over to Satyajit.
Thank you, Sandipan, and thanks and a good evening to all my colleagues and friends in Guwahati. Sandipan said that I should talk about science and the pandemic. So what I'm going to try and do is do a little combination of not simply what we know about COVID-19, what we know about the virus that causes it, namely SARS-CoV-2, what the possible responses are, what responses there have been, and what the gap may be, what the current vaccine situation is. But I'm going to try and do this in, if you will permit me, in relatively short time as a broad initial set of comments, because I would much rather respond to questions and to conversation. Please note that it's not that I'm going to give you authoritative answers to questions, but since I've been following this and since it's my field, I might know a little more by way of evidence and a framework of understanding, and therefore my responses might help. And I would very much that we discussed what people have as questions, comments, issues, problems, rather than me telling people what they ought to be interested in and what they ought to know. So with that, let me start with what I'm calling my broad outline. So clearly, epidemics are caused by transmissible illnesses. So both words are important. Transmissible, meaning ordinarily going from one person to another, and illness, meaning that we're talking about a disease. It's an odd thing to realize that it's quite likely that lots of new viruses, for example, come into humanity all the time, and we don't even notice them. Because think about this, if SARS-CoV-2 and COVID-19 had not caused 10% of the people who are infected to become seriously ill and about 0.5% to actually die, if instead they had only caused 0.1% to become seriously ill and 0.001% to die, we wouldn't even have noticed a pandemic, even though the infection would have been spreading. So when we think socio-culturally as well as in medical and administrative terms, when we think about an epidemic, pandemic is just a global epidemic. When we think about an epidemic, we are really talking about these two elements, something that is transmissible and something that is a serious illness, that has a major component of serious illness. So what's transmissible? So for until about 150 years ago, we had no real idea of what exactly transmissible meant. It was only when we realized that there are microscopic life forms, germs, microbes, whatever we like to call them, that there are microscopic, extraordinarily small life forms, that we realized that those life forms can come into the body, can grow in the body, can generate a reaction from the body, and the interplay between the microbe and the reaction of the body can give rise to disease. And I'll come back to this idea in a minute. But the fact is that until we realized this, we had no sound basis on which to understand the mechanisms of disease transmission. Let's keep in mind, since we are in a respiratory disease pandemic, let's keep in mind that there are other ways that disease can spread. So the most striking example I will give you, because it's a common enough term, is the bubonic plague. The bubonic plague does not spread directly from person to person. It spreads by rat fleas. Although there is a respiratory version, there is a lung version of plague, which is called pneumonic plague, which does spread from person to person. But by and large, we think about infectious agents, microbes, germs, going from the affected person to somebody else, causing serious illness in at least a large proportion of people. So when do we notice that there is a pandemic? When people start dying, when people start becoming very seriously ill. So how do we how do we realize that there is an epidemic? We notice transmission of a serious illness. What's the way of noticing transmission? The way of noticing transmission is that there are more cases of a serious illness than would be expected. And this is particularly so if they happen in clusters. And clustering means clusters when they happen very close in space, meaning in same neighborhoods and in a very short period of time. And you say, oh, there is an outbreak of illness. And if the signs and symptoms of the illness look pretty much the same, then you have a reasonable case of, the famous definition of the duck. If it walks like a duck, if it quacks like a duck, it's a duck. So even without identifying the microbe, we have some notion of an epidemic outbreak. So this is what happened with COVID-19. We began to notice it when people began to turn up in hospital with pneumonia in clusters. So the next question is, how do we identify the microbe causing the disease? So again, for 100 years, until 100 years ago, we really had no good way of identifying viruses causing diseases. We had ways of identifying bacteria causing diseases because by then we had figured out, the scientific community, but really humanity, had figured out ways of cultivating bacteria from clinical sample material, from throat swabs, from blood, from this, that, and the other, and growing bacteria and identifying bacteria as causing the disease. Viruses were still a complete unknown. So I should really ask, we talk about the 1918 flu. How did they know that it was a viral illness? They didn't. They knew that it was a transmissible illness, and they thought it was not a bacterial illness. So by a process of elimination, they said it's a viral illness, because influenza was what a set of signs and symptoms was called. It was called that because the nose dripped, because people were coughing, people had pneumonia, people had fluid in their chests, they couldn't breathe. They obviously were not getting enough oxygen, they turned blue and they died because of lack of oxygen. And that was a pneumonia. And when lung samples were looked at under the microscope, the samples didn't look like those of bacterial pneumonia. So everybody said viral pneumonia. And this is how the 1918 flu was primarily identified at the time. So after that, steadily, decade by decade, virus culture became possible. So you could cultivate viruses. But cultivating viruses from clinical material and defining which of the many viruses that grow out is actually causing the disease is not simple and straightforward. In the first place, because all viruses are not easily cultivated. They can't be easily grown in petri dishes. So in all of this, in this century, over the past 20 years, what has become possible is to just take clinical samples and to determine the genetic sequences of all microorganisms in that sample, and then to identify, is there a new sequence? And that is how SARS-CoV-2, the causative agent of COVID-19, was identified. So let's think about SARS-CoV-2 and the disease, the virus and the disease. So everybody keeps referring to it as corona, and we really shouldn't be doing that. Part of it is just me being pedantic, but part of it is also that SARS-CoV-2 is just one member of a very large family of viruses called coronaviruses. Corona, like the solar corona. Corona is crown in Latin. So coronavirus is crown-shaped viruses. Under the electron microscope, that family looks like as though they are in the shape of a crown. So there are literally hundreds of coronaviruses. So we shouldn't really be we shouldn't be blaming all of them for the deeds of one family member. So all the coronaviruses that we know, this is not the first coronavirus family member we've identified. This is actually, I think, the 7th member of the coronavirus family that humans have encountered. 4 of them actually just cause common, ordinary cough and cold, mild illness, which is why we wouldn't even notice if there was a 5th one. But in this century, over the past 20 years, we have had, this is our 3rd encounter with a coronavirus family member. 20 years ago, there was a disease called SARS. 10 years ago, there was a disease called MERS. And today, there is the disease called COVID. And all 3 of these have 2 things in common. Number 1, They are all three viruses that are members of the coronavirus family. And number two, like all other the previous 4 viruses of the coronavirus family, these viruses also cause transmission from breath to breath. So, if I'm an affected person, my respiratory tract, my nose, my throat, the tubes going into my lungs themselves, somewhere there is infection. So the virus which is growing, infection simply means microbe is growing. So if the microbe is growing, it's coming out into the fluid that is there in all my airways. And therefore, when I cough, when I talk, I sneeze, I laugh, droplets come out. We are all familiar with this in classrooms, that droplets come out of mouths and noses. And the big droplets are heavy, so they fall to the ground. Now you can imagine that a droplet is laden with virus particles. Small droplets with hundreds, large droplets with thousands or tens of thousands. So clearly, if I'm sitting very close to somebody and that person is affected, and my brother talks to me and he is affected, he doesn't realize it, droplets come in from his breath into my breath, and they go and sit somewhere in my lung. That droplet goes and falls somewhere. As an aside, please keep in mind that we are talking about small droplets, large droplets. There is a whole spectrum. There's a whole range of droplet sizes. And the smaller the droplet is, there are 2 issues. Number one, the number of virus particles in the droplet, each individual droplet becomes smaller and smaller. But the droplet stays suspended in air for longer and longer, and therefore can spread out a little longer. But because it is spreading, it is diluting, and because it is small, the amount of virus in it is small, so it's less efficient. But this is the complex situation because of which large droplets are more likely to transmit infection in the open air. Small droplets are much more likely to transmit infection in closed environments, particularly with recirculating air. So that's something that we all should keep in mind. Essentially, the virus simply goes from breath to breath. So, okay, the droplet lands on the back of my throat, say, right? And it goes and falls in the fluid that is covering the wall of my throat. So virus particles will sink down and will roll about on the cell. The cell is really large compared to the virus particle. So the virus can't do anything unless it is stably attached. And for stable attachment, there is a protein on the surface of this particular virus called the spike protein. And there is a protein on the surface of many of our body cells. The protein is called the ACE2 protein. And these 2 proteins, if they come close, can actually lock together. And it is this locking that is the important step for the virus to infect the cell and to begin the process of infection and disease. But also, this is the point that we interrupt mainly when we use vaccines. So we'll keep coming back to this for a few minutes, in just a few minutes. So once a stable interaction is done, you have the virus nucleic acid being injected into the cell. Oh, absolutely. Swandipan just said anybody can ask questions, and please feel free either in the chat box or just raise your hand, and I'm happy to stop and deal with questions. So as the virus sticks stably, the particle gets the opportunity to transmit the genetic sequence of the virus into the cell. The genetic sequence of the virus now takes over biochemical processes of the cell. And as it takes over biochemical processes of the cell, it begins to manufacture its own copies. Because the manufacturing of the copy is like copying a letter by hand, so you will always make an occasional mistake in transcription. That's what happens to the virus, and that's where variations are generated in the virus copies. And the variations are important, as all of you will realize, in thinking about what are called variants and so on and so forth. So that's the biological process through which variants are generated. Having made copies, the virus then damages the cell sufficiently, either because it has taken over the biochemical processes of the cell, which are actually the housekeeping processes of the cell. So so the housekeeping of the cell is not happening, so the cell gets sicker and sicker, finally breaks open, or the virus sometimes breaks the cell, and virus particles come out. They spread locally to other cells, but they also come into the fluid and get coughed and sneezed out and go into other people. So we are talking now about the virus beginning to grow both in my body and getting transmitted from me to somebody else. But in this process, the body notices when the viral genetic sequence comes into cells, because cells have a mechanism for sensing viruses. And that mechanism now generates two kinds of responses. One, it generates so-called interferon proteins, which create a little zone of virus-resistant cells. So basically, it creates an antiviral situation where it is limiting the virus, keeping its growth under control. And this you will find interesting because interferon is actually used as an antiviral drug. In fact, there are clinical trials for interferons in COVID-19. They haven't been very successful, but they've been there. On the other hand, the other immune response that happens, the second immune response that happens immediately, is that proteins called the cytokines build a little microcontainment zone at the point where virus is growing. Not everywhere, mind you. And not everywhere is important, because when this microcontainment zone is built, it is built by inflammation. And because it is built by inflammation, it succeeds in two things. It succeeds in managing some amount of local containment of the virus, and it also brings in other cells of the immune system to come in to recognize the virus and to start more long-range reactions to the virus. But in the process, the inflammation also causes local damage on its own. So when we get disease, part of the damage is caused by the microbe, part is caused by our body's response to the microbe. Inflammation causes swelling, inflammation causes oozing of fluid, so we are the throat gets irritated, we are coughing, there is a lot of fluid, so we are coughing up phlegm, and if the fluid is further down in the lungs, then we are talking about fluid accumulating in the lungs, so oxygen carbon dioxide exchange does not happen very well, and you have a major difficulty. Now, having therefore come to this, you will realize that as disease progresses, initially virus grows, the immune response comes up. The immune response gets control of the virus, and therefore the amount of virus begins to go down. And slowly, as the amount of virus begins to go down, the immune response goes down. In this process, depending on how much virus you have been exposed to, and depending on how quickly your initial immune response took off and began containment, the amount and the spread of virus in the body may be quite a bit before the immune system gets a handle on it, which means that by the time the immune system gets a good handle on it, it may be bringing the virus load down, but it has caused so much inflammatory damage in the lungs that it is now making it difficult for the patient to breathe. And that is serious and severe disease. And this is why what is required for severe COVID-19 illness, in addition to oxygen to support the body in maintaining oxygenation, is drugs that are bringing inflammation down, that are suppressing the immune system. And I don't know if you have heard Ornalok Chakraborty, but if you, but Ornalok, who is an expert in fact, one of the country's major experts in mucormycosis and related fungal infections, he will point out that if you suppress the immune system too much, then you run the risk of things like mucormycosis. So treating COVID-19 patients has this balance. Antiviral drugs, by the time severe disease happens, antiviral drugs are not very useful, primarily because in most cases the body is gaining good control over virus growth, but it is the anti-inflammatory drugs that are useful, and oxygenation and maintaining oxygenation. But anti-inflammatory drugs, particularly immunosuppressive drugs, are a double-edged sword because they can then allow other secondary infections to progress. The problem with all of this is that we haven't met this virus before until a year and a half ago. As a result, this is the immune response we have. So what happens if you have met the virus first? Let's consider that, and we go to the vaccine situation. Let's consider that in my example, I catch the virus from my brother. It goes in, it begins to grow. I begin to respond to it. We have a little tussle. But eventually, with some symptoms, I gain control, virus load goes down. In the meanwhile, I have spread the virus to other people, but virus load goes down, inflammation goes down, I have recovered. But in the process, remember I said that the inflammation brings in cells of the immune system into this location. And these other cells of the immune system generate long-range, long-term responses. The most famous of which is the antibody response. And for understanding what the antibody response does, let's go back to how the virus particle infects the cell. So the virus particle must come and stick very closely. So a protein on the virus surface and a protein on the cell surface have to lock together. So the virus has a spike protein, which is how it is going to get it. What the antibody response does is it recognizes the shapes of the virus protein and it makes special proteins called antibodies that go and stick to the virus surface, to the shape of the spike protein. Essentially, they put a cap on the spike protein. And if they put a cap on the spike protein, then the spike protein can no longer go and stick to the cell. And therefore, virus particles cannot establish infection. And this is why you have the virus causing, the antibodies causing a prevention of virus infection. So no, the virus is not causing a psychological illness, neither is cancer causing a psychological illness. In rural areas, people are found with symptoms and nothing happens, and quite frequently nothing happens, in part because we are not testing people in rural areas. India is a country that has massive inequity between urban and rural parts of the country, in addition to other kinds of inequities. And therefore, in cities, there is a little more testing and a little more reliable testing. Even in cities, the higher income areas have more than the working class areas. But in rural areas, either because there's no testing or because sampling is not done under ideal conditions and circumstances, and therefore sampling is suboptimally done, the tests frequently come out to be negative. But this is not a psychological illness. Neither is cancer, neither is any form of cancer a psychological illness. But the evidence that you're pointing to is absolutely real, and that is not so much medicine or biology as our social policies in responding to the pandemic. So, so here's the point. I have recovered from my first exposure to the virus. Now, if I meet the virus again, if virus comes back into me, my body fluids, my blood, my fluids in my nose and my throat, all contain antibodies, because antibodies last for a long time. As a result, the incoming virus, I am now even better able to prevent its establishment and growth. And this is why if I'm infected for the first time, then I generate an immune response that helps me bring much better control on the virus when I meet it next. And basically, this is a vaccine. Because all I have to say is, hey, let's take a healthy person and give this healthy person virus, not actual virus, because actual virus might cause serious disease. Instead of giving this healthy person actual virus, let's give this healthy person a mimic of an actual virus. The mimic should have two properties, two characteristics. One, it should not be able to give any real disease. It should not be able to cause disease. And two, it should nonetheless look to the immune system enough like the original virus so that the immune system will get very stimulated and start making antibodies, and those antibodies will recognize the original virus. And if I can do this, then I have designed a vaccine. And this is the basis for all COVID-19 vaccines. This is not simply the basis for all COVID-19 vaccines. This is the basis for all vaccines. I urge everybody to keep in mind that for the young people who are listening to this, all of you have been vaccinated when you were born, when you were not even a year old. Month by month, you went and got injected either in your arm or in your thigh, depending on how chubby you were. And as babies, not now. And if for the older people, everybody has taken their children as newborns, as infants, to be vaccinated. Every vaccine is based on this precise principle. We are giving a safe mimic of an infectious agent. Safe because it will not cause disease. Mimic because to the immune system at the molecular level, it looks enough like the original infectious microbe to generate immune responses that can recognize the microbe when the real microbe comes in. And therefore, every vaccine generates immune responses against one specific infectious agent, which is why babies need so many different vaccines, because we vaccinate them against 6, 7, 8 different infectious diseases, which is why COVID-19 vaccines. So let me pause. I will go back to vaccines, but let me respond to questions. How does mast cell activation in response to the virus affect our body during post-COVID recovery process, and how to reduce it? If you mean mast cells, meaning allergic cells, the evidence that mast cell activation is primarily responsible for post-COVID symptoms is extremely weak. So at the moment, we don't even really know if this is a fact. And this is what is happening quite frequently. In pandemic times, because we are all afraid, there is a great deal of claims out there that are not really solidly based on evidence. So is it possible that mast cell activation, mast, M-A-S-T cell, is what I think you mean? And please correct me if that's not what you mean. But if that's the case, then is it possible that that happens? Yes, but many things are possible, but they don't happen. Do we know that that is the case? No, we don't. And therefore, at the moment, to start worrying about how to reduce it is putting the cart before the horse. We need to figure out whether it happens or not. At the moment, what I have seen a fortnight ago, mast cell activation does not seem to be necessarily the major player. Is it seen in some individuals? Yes, it is. But is it primarily seeming to be responsible for post-COVID, long COVID symptomatology? It doesn't really look like that. The vaccines which are being given now are the vaccines produced from the original COVID-19 virus. Okay, so this is a mutation question. I will hold the thought. I will come to the mutation question in just a few minutes. It's a great question, and I'll come back to that. And the mast cell question is a great question because it allowed me to talk about evidence. And the next question is it the amount of virus at first interaction somehow determines if the patient would? That's a great question. And Again, I'm going to give two separate responses to that. You will realize that I'm not answering questions in any definitive fashion. I'm just pointing to ways of thinking about it. So, is it likely that the amount of virus is a major determinant? Absolutely, yes. Why am I saying this? So let me give you a piece of evidence that researchers in the field use to think that the amount of virus is important. Remember that, for example, on a cruise ship, right? There was a cruise ship last year called the Diamond Princess, where huge number, hundreds of people got infected, 600, 700 people got infected. Remember that on a cruise ship, because everything is centrally air conditioned, essentially the entire cruise ship with 1,000 people on board is very much a single air handling unit with recirculating air. And because everybody tries to be cheap, we all know this, putting really stringent filters reduces the speed and therefore increases cost and so on and so forth. So most of these times, these things have very little air filtration. So the air is circulating, and because the air is circulating, lots of people got infected. But because the air is circulating, people were infected with prolonged exposure to the same recirculating air. And the proportion of symptomatic, I'm responding to your question, the proportion of symptomatic people on the Diamond Princess was much greater than the proportion of symptomatic people in community transmission, where a lot of transmission happens over much shorter periods of time or in the open air with just a transient exposure. And as a result, you have more than 50%, more than 60% of people infected were asymptomatic, not on the Diamond Princess. So, your point is perfectly well supported by data. But is it the only determinant of symptoms? No. Why am I saying this? Because the most severe infections, the most severe illness that results in death is caused disproportionately frequently in people who have comorbidities. Age is a comorbidity, so I'm already comorbid because if you're 60 plus, then you are at very high risk relatively of getting severe illness in COVID-19. If you have hypertension, if you have diabetes, if you have other most chronic diseases seem to predispose. Extreme obesity seems to predispose to severe COVID-19. And nobody has so far definitively figured out what the mechanism is of this. So anybody who tells you, oh, we know how this happens, no, we don't. And we should stop pretending that we do. I know that it is important for all of us to feel that this is under control, and knowing things is an empowering way of feeling under control. But it is also true that when we take rational, evidence-based approaches to understanding disease and to developing public policy and strategies for the common good, evidence matters. Good evidence matters. Rational causality determination matters based on evidence. And therefore, we got to wait and see. At the moment, we don't have a good explanation for why the elderly, the obese, the diabetic, the type 2 diabetic tendencies, other people who have chronic inflammatory diseases tend to have more frequent severe illness. A guess is that because their inflammation levels in the body are quite high, their ability to respond very rapidly by increasing inflammation even more rapidly is a little bit slower. And that allows the virus to spread a little bit before their immune system finally gets going and begins to bring it under control. And that's why effectively they sometimes go over into severe illness. But is that proven? No, it is not. So all we know at the moment is the correlation. the vaccine point I'll come back to. Oh, thank you for confirming it's masked. No, it's fine. I thought that's what you meant. Can we increase the efficiency of interferons of infected cells of your body by using any therapy from outside? That's a great question. And there are people working on it. Here is the difficulty that I would dearly like for you to keep in mind. And that is, if I inject interferon into the body, then every cell in my body, whether it is close to any source of virus infection or not, will get activated and will start doing all sorts of re-engineering of its biology. This is going to have cost. This is exactly what happens with all these stupid immunity boosting quack drugs that are in the market. Believe me, they're all quack drugs. Why? Because if they boosted and activated my immunity all over my body, then I would have, for example, inflammation all over my body. And it is therefore a great mercy that these are really quack drugs, that they don't have any effect on the immune system. Or the only effect they have is in filling the pockets of the Babas, the Maharajas, the Vaidus, the doctors, the pharma companies who are selling this rubbish. But the mechanism point there that we need to keep in mind is that we need these responses, whether interferon responses or later immune responses, in the location where they are needed, in the body, in the location where they are needed. And the real catch with increasing the efficiency of interferon of infected cells is how to take those drugs and bring them to the place that they're needed and ensure that they will act only in that place. But it's a great question because I don't know if anybody has seen this. Yesterday's newspaper has a piece of news that the US government is going to put $3 billion into discovering antiviral drugs with specific properties. And I know some people in the US who are working on precisely what you are asking as a possibility for that. Person who tested positive for COVID-19, I'm just reading the chat box question. Person who's tested positive for COVID-19 and has not gotten suitable dose for vaccine. Okay, so that's a vaccine question. I will come to the vaccine question as I go forward in vaccines. So let me talk about, therefore, vaccines. So I said that we are going to show a mimic of the original virus for COVID-19. How did we come up with COVID-19 vaccines? 20 years ago, we met a cousin of SARS-CoV-2 called causing disease called SARS. 10 years ago, we met another cousin of theirs causing the disease called MERS. These were far more lethal diseases. What do I mean by far more lethal diseases? Let me explain that with numbers. If 5 people were infected with either the SARS virus or the MERS virus, infected meaning that the virus had entered, same way, respiratory entry, the virus had entered and was growing in some location in the back of the throat, somewhere down in the lung tubes and so on, and had begun to make copies, had begun to make progeny. If you took 5 people like this for SARS virus or MERS virus, 1 or 2 of those 5 people would die. If you take 100 people infected with today's virus, the COVID virus, maybe 1 would die. Actually, less than 1, but maybe 1 would die. You see what I mean by the difference in the severity of illness and lethality. SARS and MERS were far more lethal, individually dangerous than COVID is. So why do we not hear about them? Well, we heard about them when they came out for the first time, and because they were so lethal, exactly like the Ebola virus disease, which is also similarly lethal, actually even more lethal perhaps, groups of public sector scientists began to make vaccines, began to design vaccines, develop vaccines with all these technologies. The mRNA technology came up then, the adenovirus technology came up then. All of these technologies are 20 years old. They began being made as vaccines, candidate vaccines. They began being tested in clinical trials. And then now you're going to turn around and say, but we didn't see any pandemic and we didn't even see any vaccines. Sure you didn't. Why? Because by the time the human trials of these vaccines had progressed, something very peculiar had become evident. And what was peculiar that had become evident was that what is our first response when we have a respiratory, breath-to-breath transmissible spread of infection? We begin to do physical distancing. We've been doing physical distancing for a year and a half, right? Some of us are doing it better, some of us are not doing it as well, but there's been physical distancing the world over. The point was, SARS outbreaks, MERS outbreaks, halted completely with physical distancing because the viruses are really not very good, not very efficient at spreading. COVID, the virus, is not particularly lethal compared to its two 10-year-old, 20-year-old cousins, but it is really good at spreading. So what happened 10 and 20 years ago, by the time vaccines began to show good promise in clinical trials, there were no outbreaks that couldn't be controlled. Outbreaks were controlled simply by physical distancing. As a result, nobody wants a vaccine. There's a little twist to this. What is the twist? All the vaccines got designed, innovated in public sector research institutions, universities, public sector laboratories. But because we, with the sort of kind of exception of China and Cuba, nowhere in the world are there really credible public sector pharma companies who was developing the manufacture and the downstream process development for these vaccines. Private sector pharma companies. And private sector pharma companies then and now are not interested in the public good if they can't make profit, either monetary profit or non-monetary profit out of it. So since the SARS and MERS outbreaks were controlled without a vaccine, they knew that there was going to be no demand on vaccines, and therefore they stopped. They put the vaccines back on the shelf. Last year, when two things became evident. Number one, that the COVID virus was not as lethal a coronavirus, but that the COVID virus was not going to be controlled without a vaccine either. That's when all the companies took their earlier vaccines down from the shelf, said, oh, we have coronavirus family vaccines that show quite good prospect. So all we have to do is to tweak it so that now they are against COVID and we can very rapidly move forward. This is how science and technology works cumulatively. It's nothing, there's no miracle about COVID vaccines. See, calling it a miracle undervalues the durable, communitarian, inclusive basis of science and society. This is what science does. It learns lessons, it builds on them, it does the next thing. And that's what we've done. So this is how every vaccine, the mRNA vaccines, the adenovirus vaccines, all of these have come from earlier designed vaccine candidates against SARS, against MERS, against Ebola. And this is how we've come up with not one vaccine, but a whole portfolio of vaccines. All of these vaccines have been safety tested, perhaps more than anything is safety tested for ordinary regulatory approval, but they still don't have regulatory approval, ordinary regulatory approval. What they have is emergency use authorization. Why is that? Is that because there have been shortcuts? Not on safety. There have been no shortcuts on safety. Then what has there been a shortcut on? On testing to see whether they work. How do you test to see whether they work? You take 20,000 people, don't give them vaccine, and give them sham vaccine, 20,000 people to whom you give your vaccine candidate. And now, month by month, you're counting COVID cases. And first month, you get 20 cases here, 5 cases here. Second month, by the end of the second month, you've got 50 cases here, 17 cases here. By the end of the third month, you've got 90 cases, you've got 25 cases. And as you hear these numbers, by the end of the second or third month, it's very clear to you, it's like election trends. On some seats, it's very clear from early trends, what's going to happen? You know what the outcome is. That's what has happened with all of these vaccines. Their early trends are clear in saying that the vaccine will reduce the likelihood of disease in the vaccinated group. The vaccines are safe, the vaccines will reduce it. Therefore, at the individual level, in an ongoing epidemic, the vaccine ought to be taken by everybody. So license the vaccine for emergency use. Why not just approve it? Because we don't know two things about it. And as you, I hope, will realize, I'm as frequently talking about what we don't know as I am about what we know. So there are two things we don't know. Number one, we don't know what the final exact number of protective efficiency is going to be. Remember, when you have an election trend where early trend says this seat is going to, this candidate is going to win, you know that. But what you don't know is what the final margin is going to be. The trend doesn't promise you, allow you to predict a final margin. That's what's happened with these clinical trials. The trials are still going on because the trials are 1.5 years long. No trial has finished 1 year yet. Well, the first Moderna trial is just finishing 1 year. So as a result, what you have is, you know that the vaccines have a reasonable protective value. You don't know exactly how much. This is why, please do not believe the 60%, 70%, 80%, 90%, 92.4%, all of that, because we have let pharma companies, for-profit companies, make this product of social good for us. They are talking advertising numbers at us. They really don't know as yet. We are going to have to wait and see the final numbers as they come out. What we know is that the vaccines are worth taking. What we don't know is which vaccine is better and stuff like that. What we also don't know is how long will the vaccine result last. One of you is asking this as asking a question which is clearly related to this. Is the vaccine going to give lifelong immunity? I'm reading the question. Or do we need to take booster shots periodically in the future? We don't know. What we know is, because the clinical trial is testing people, volunteers in the trial. Remember, people in clinical trials are not subjects. They are participants and volunteers. So since volunteers are being tested in the trial regularly, what we know by now is, with the Moderna vaccine, the Pfizer vaccine, and the AstraZeneca vaccine, which is what is mostly found in India, which is the Covishield vaccine, up to about 10 months after the second dose, the protective antibody levels remain pretty high. So no booster needs to be taken. I suspect that this means that we're not going to need to take a booster at least for 1 year, possibly for 1.5 years. How much beyond that will we not need to take a booster? I don't know. Nobody knows. We have to wait for the evidence to decide. We should not let anybody make casual predictions about this. We should wait for the evidence to decide, but we should keep pressing that the evidence must be told to everybody transparently. That's important. So that said, let me deal with two other questions that I was going to bring up, and that I'm delighted that it's come up. When I take a vaccine, what am I doing? I'm taking a mimic of the original infection. So my immune system must feel that there's something dangerous has come in. So the vaccine formulation should cause a little bit of damage, right? So what all vaccines do is cause a little bit of local damage. So for all vaccines, all of us have taken tetanus shots, right? For all vaccines, locally, there's a little bit of, you press and there's tenderness, it swells a little, it's a little red. That is enough. Even very, very mildly, that is enough for the immune system to be stimulated. But the trouble is, We don't. We have a great deal of variability amongst us. So some of us have a little more of that inflammation. In some of us, it sort of spills over into the body and causes fever and causes body ache and can cause dizziness and diarrhea a little bit. But all of those are transient, 1 or 2 days. Other than that, there are no dramatic common ill effects of vaccines. Because we are doing this, the question now becomes, I'm taking a mimic of an infection. What that means is that if I get the actual infection, that's also equivalent to a vaccine shot as far as our vaccine strategy ideas are concerned. Absolutely, yes. There is a reservation there, and that reservation is the actual live virus, because the virus has co-evolved with us over generations of virus. Remember, each virus generation is only 1 or 2 hours. So over generations of virus growth, the virus sometimes has, and many coronaviruses sometimes have, ways of modifying the immune response. In the vaccine, those ways of modifying the immune response don't exist. And therefore, vaccine-generated immunity is different from virus-generated immunity. In part, virus-generated immunity can be more intense, but in part, virus-generated immunity can be more variable than vaccine-generated immunity. All of those reservations aside, the infection, actual infection, is just another vaccine dose, right? For the long-lasting immune response perspective. And if that's the case, then what we are talking about is what should be the gap between 2 doses? And the answer is very short, flexible, and straightforward. When you take a vaccine, whether real infection or vaccine, your immune response begins to be generated. Then you clear the injected material, your immune response quietens down. But what it leaves behind is a certain level of antibodies. It is at this point where that specific immune response quietens down, that if you give it another dose, it will now begin responding even better, and it will lead to a much higher antibody response. So what you want is to leave a gap for the initial immune response to come back to quietude before you trigger it, which means leave 3-4 weeks between doses. But if you leave 3-4 weeks between doses, then you can take the second dose anytime up to 8-9 months, and you will get a better response. I promise you will get a better response. So the immune system is quite flexible and forgiving. All the other considerations of spacing between doses are practical considerations of vaccine availability. All the reports that you are seeing in the newspapers about, 4 weeks or 6-week gap is better than 4-week gap, 12-week gap is better than 8-week gap, all of those differences are really small differences. It's not clear whether they are statistically significant even. They are not differences that any of us ought to be worrying about. What we should be worrying about is the collective matter. And the collective matter is our vaccine supply shortage is our collective concern. And if we have a vaccine supply shortage, then I think what the technical committees of the government are advising, can we extend the duration, can we extend the gap so that we have more vaccine available to at least cover as a first dose, is a good thing. We really should be asking our governments, why do we have a vaccine shortage? Why have we not done better planning? Can we do better planning now? What are the short-term and the long-term measures that we should be doing, both in science and technology, as well as in public finance and policy, for recovering from the shortage? That's a collective question for us to ask. So that's my answer to the lifelong immunity question. Let me come to my last point before I go back to answering questions. The last point is, remember that the virus is generating mutations. Now, the virus is not responding by making mutations. The virus doesn't think. This is simply virus populations evolving. What is happening, as I pointed out, as virus copies are made, there are small variations introduced. Usually they don't matter, neither to the virus nor to us. But over the last 1.5 years, what we've been doing is we've been physically distancing. what we have done is put evolutionary selection pressure on the virus. We've made it harder for the virus to transmit, correct? Which means that if a virus variant happens to have the property of spreading, transmitting efficiently, even when hosts are maintaining distance, then that's the virus variant that will begin to grow because it will have a growth advantage. We are giving it a growth advantage. And as a result, the variants all over the world that are coming up as prominent, this year's strains, let us call them, this year's strains are all more easily transmissible. They are not more lethal. There's a marginal increase because they are more transmissible between cells in the body as well as between people. But that's really not a major issue. Similarly, it's not that they are immune escape variants, because that's not the selection pressure that is currently driving their selection. They are, at this point, simply more transmissible variants. So the question is last year's infection or last year's strain-based vaccines, which are all the current first-generation vaccines, are those immune responses capable of protecting against these strains? And the answer seems to be a qualified yes. And the answer is beginning to come out only in these last few days and weeks. So evidence is coming out as we speak. And the evidence seems to be saying that those vaccines are protecting extremely well against serious illness and death. And therefore, at the individual level, absolutely yes. We've got good effects of the vaccines. Are they protecting against asymptomatic or very mild infection? They are, but not as well as they are protecting against severe illness and death, which means that transmission is only mildly reduced, which is going to create a problem. And that problem is brought up by, Chandupan's question, which is vaccination going to put evolutionary pressure on the virus? Yes, it is. And we know that this happens. This is not the first time it is happening. We know it happens. This is what happens with influenza. Influenza viruses, as we become immune, a different strain begins to be selected, which is not really well protected against by the existing immune response. So we get a new strain. And we have a system worldwide to respond to this. We have a WHO benchmarked, WHO coordinated global influenza virus monitoring and surveillance system. Annually, we decide what the strains of next year or this year are likely to be, and vaccine companies start making vaccines against those strains and bring them in the market for that year. We have a system. That's what's in all likelihood we are looking at with COVID. That slowly, as vaccination spreads, the virus will start generating variants. Now, influenza generates variants much more rapidly than coronaviruses do. There is a difference in the biology of the influenza virus family versus the coronavirus family. And therefore, variant generation amongst coronaviruses is slower than in influenza viruses. But is it possible that we will eventually begin to see vaccine-resistant COVID virus variants? Yes. At that point, we will need next-generation vaccines. Today's vaccines work quite well to protect you from severe illness and death, even with this year's strains. We know viruses are intracellular parasite, what types of cells are suitable. Right. So, no, they don't destroy blood cells. Viruses will get into any cell where they can dock on the surface. Right? So, they can therefore dock on any cells of the lining. And this is how Bharat Biotech in Hyderabad is making Covaxin. What they are doing is they're taking a human cell lineage, fibroblast cells, cells, or epithelial cells, fibroblast cells, actually vero cells, so fibroblastic cells, and they are infecting the cells with the COVID virus. They're allowing it to grow, then they're harvesting the virus, they're inactivating the virus with a chemical called beta-propiolactone, and that's the inactivated virus mixed with a little bit of an immune stimulant called an adjuvant. That's covaxine. So that's how vaccines are made. So are we going to take these vaccines? Yes. Are we going to get terribly worried about this? No. Are we going to remain careful? Yes. Why? Because none of these vaccines are providing, particularly providing the collective component of protection. They are not really cutting transmission of infection down to less than 90%. And therefore, we need to maintain physical distancing while the vaccination acquires equity. The real question is, can we vaccinate all our people, not just the most well-off or the urban people, but all our people? The question is, while that happens, can we maintain our livelihood support, our economic support in this disrupted cycle with lost livelihoods for the poor, the marginalized, the disempowered? Can we make a societal decision to invest our wealth in maintaining livelihoods, invest our wealth, our common wealth, in maintaining vaccine supply flow so that we will reach equitable vaccination, maintaining livelihoods? That's the question that all of us should be collectively asking. Let me stop here, and I'm happy to respond to questions. What approach should our country take to tackle the COVID virus situation? I just said what I think we should do. We should invest much more and far more durably in public healthcare systems. Remember, when we have sick people in rural districts and taluks, you cannot put them in ambulances and take them to Guwahati. We need critical care facilities that are decentralized across districts and are accessible to poor patients. We need a network of organization and of ambulances where we will be able to distribute patients. We need the supply chains. We need the skilled personnel. The amount of pressure that we have put for the past year and a half on all our healthcare workers, not just doctors, not just nurses, the technicians in the laboratories, the ambulance drivers, the janitors, all of these need support, need durable public employment in order for this to be a durable public health response. Number one. Number two, we need community outreach teams that will do public education, that will bring people in for vaccination, that will bring people in for testing. We need these teams also to begin to provide the community response of support. We need the government to start investing much more enthusiastically in vaccine manufacture as well as in vaccine distribution. All of this takes money. We need the government to invest, but we need the government to invest in an empowered, participatory, proactive citizenship in the community, rather than the government behaving like a big brother and instructing people to do this, that, and the other, and the people being resentful recipients of government orders. We need participatory, we need truly empowered democratic responses. Can we expect more waves in the future? So in the first place, let's not talk about waves. Even this time, let me point out, everybody is talking about this as a second wave. And let me give two examples why it's not a single uniform wave that has come up and is going away. Number one, in Delhi, this is not the second wave. This is the third wave in Delhi. Delhi, the government actually speaks about, can we expect a fourth wave in Delhi? So clearly there are local differences. Secondly, in the Northeast, where you are, and along the eastern seaboard, if you look at district numbers have at most plateaued and are going down a little bit. Whereas along the western seaboard, in districts, there are precipitate falls of numbers. This is an infection that spreads from breath to breath. Of course, it spreads in closely interacting coherent neighborhoods. It doesn't spread in nationwide fashion. We should stop referring to it as a wave. We should stop referring to it. We should start referring to it as local outbreaks. We should think at district level. That's where our empowerment is. That's where the infection is spreading. That's where we need communities to draw on government resources to respond locally. So politics matters, political perspectives matter as much as the science and technology matter. But can we expect more outbreaks? Absolutely yes. Because are we all immune? No, we're not. This entire notion of herd immunity is just wishful thinking. We don't know for a new disease what the herd immunity level is. So everybody is just a guess. And in any case, we have no way reached in most places in the country anywhere near the total of people already infected versus people who have been vaccinated to be the majority of people. Very, 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 very few taluks this will have happened in. Primarily the urban rich who will have been vaccinated. And to some extent, the urban working class neighborhoods, which last year were extensively infected. But other than that, we haven't reached that level. And so long as we haven't reached that level, every time we begin, both society and government, to pat ourselves in the back and say, oh, wave has gone away, infection is receding, we have triumphed, we have won victory over evil COVID. Every time we do that, we fool ourselves enough into both beginning to be less and less careful, less and less aware, and in withdrawing the support systems for both livelihoods and hospitals and vaccinations. And all of that is inviting new outbreaks to come up somewhere or the other. This is a fundamental issue. Remember, we are responding to this in disaster management fashion. But there is a basic difference between a disaster like, say, a flood or an earthquake. The flood has come and gone. The earthquake has come and gone. Now we are left dealing with the aftermath. That's a far more short-term response to the crisis. Our response to the COVID crisis has been marked by this short-term perspective. But infectious epidemics are not short-term. I will end by pointing out a historical fact. We refer to the influenza virus epidemic of early in the 20th century as the 1918 flu. This is correct. It was the 1918 flu, and it's a much better name than the alternative bloody colonial name, which was Spanish flu. There was nothing Spanish about the flu, and we shouldn't be using geographical stigmatizations anyway. But here is the catch about the 1918 flu. The first outbreaks in the world of the 1918 flu were in the spring of 1918. The last outbreaks of the pandemic of the 1918 flu were in the autumn of 1920. The pandemics circulated around the world for 2.5 years. We need to stop pretending that it's a really short-term crisis. We need to dig deep, we need to dig collectively and respond to it in sober, careful, evidence-based fashion. I will stop there. We've already gone over the limit of 1 hour that Sandipan had specified for me.
No, it's fine.
And we've dealt with
Vasudeva was saying he is a faculty in IISER Bharati. he has raised.
Yes.
Can you hear me, Satyajit?
Yes, sir. So can you hear me, please? Yes, sir. Say a person who suffered from COVID-19, afterwards he suffered from the black fungus, that is mucus something, that one.
Mucormycosis.
Now he is recovering. He is recovering in all respects. Now that person has to take vaccination in future or not? What is to be done?
Yes, absolutely yes. Mucormycosis is an unfortunate side effect as much of therapy as of the COVID disease itself. It's awful to deal with, but for somebody who's recovered from mucormycosis, there is no immune problem at all, and vaccines can be taken. So the standard, currently government says 3-month gap, and which is all right. It's driven as much by practical considerations as by scientific evidence, but that it's a reasonable combination. So taking the vaccine doses with those currently government set gaps is just fine. There is no difficulty. Vaccines are, in any case, vaccines are safe. All of these vaccines are safe, even in immunosuppressed people. So there's no safety issue at all. But over and beyond that, with the government set gap, the vaccine will be effective. So the vaccine should be taken without any concern whatsoever.
Yes, sir. Another clarification. So a person who has taken both the vaccines, first dosage and second dosage, after taking the vaccine, a gap of maybe some 10-15 days, again he suffered with COVID-19.
This is happening.
And he was admitted to hospital.
Yes.
After admitting to hospital, that person is no more. Now, how to explain this type of situation?
We have to realize that. Let me ask you a question. How many children do you think we vaccinate in India every year?
Generally.
4
Yeah.
4 crore. How many people do you think we have vaccinated with COVID-19 in 5 months?
Less number only, not all
22
numbers.
crore. 22 crore, sir.
Yeah, that's what. Out of 130 crores, only 22 crores have been vaccinated so far.
No. What I'm pointing out, let me repeat myself. How many children do you think we vaccinate every year in 5 months? We vaccinate somewhere around 1 or 2 crore children.
Mm-hmm.
In the same period, we have vaccinated 10 times as many people. Many coincidental events, many rare occurrences begin to be visible simply because of huge numbers.
I see.
So, do we have examples of people dying despite having taken both vaccines? Yes. That's happened in the US, that's happened in Europe, that's happened in China, that's happened in India. The real question to ask is not about the individual example, simply because we cannot explain individual examples. What we can do is point out, as has been pointed out, again, you will have seen the newspapers yesterday, as has been pointed out by a Christian Medical College Vellore report, that hospitalization and death after taking 2 doses of vaccine, provided you have waited, you count after 2 weeks of post second dose, deaths are down to almost zero. Severe illness and hospitalization is down enormously. It's the numbers. We can only explain on the basis of statistics. Single doses, we cannot explain. Will there be an explanation? Yes. Do we have enough evidence to find that explanation? No, we don't. We should not therefore pretend that we know the answer. We should simply point out that we don't know why, but in statistical terms, the vaccines work remarkably well. And that's about all we can do.
Okay. Thank you. Thank you, sir. Thank you very much. Thanks.
This is why I'm saying we should not over claim, over interpret over and beyond the evidence we have. It's important for us to do that.
Thank you. Thank you.
Thank you. Let me address two questions. What are the measures for asymptomatic carriers? We can't even identify asymptomatic carriers, right? I mean, because we don't test everybody all the time, except maybe in Parliament or somewhere. You know, the US president and the entire White House gets tested every week, etc., etc. We don't do this. But the presence of asymptomatic transmitters, don't call them carriers, it's for a few days, but the presence of asymptomatic transmission means that we need to maintain physical distancing as a cultural habit pattern for a while. And that's important for all of us to keep in mind. This is what I mean when I say the evidence is pointing us towards a sober reality that we need to assimilate the cultural habit pattern of maintaining as much distancing as is practical. Remember that different levels of distancing are practicable in different socio-economic circumstances. People who are well off can afford to maintain much more distancing than the working classes, than the rural poor. So for me to start shouting at everybody about how they should be maintaining distancing without understanding local situation and circumstances is irresponsible. But it is all the more important for us to come together as communities and in informed, evidence-based, empowered fashion decide for ourselves what is feasible, what is practicable, what is doable, what will save lives. So that's important. The last question I should respond to is the origin of the COVID-19 virus. This is being talked about all over all the time. You know, I keep pointing out that if this had emerged from a South American country, if it had emerged from the United States, there have been viruses there in the United States that actually killed people. They, again, exactly like SARS and MERS, didn't happen not to grow into pandemics, but there was a virus that used to be called the Four Corners virus, a hantavirus family member, that was found in the US. These things happen everywhere, and they keep popping up everywhere. If this had happened, would we have known definitively what the source of the virus was? No. Would we have gotten access for policing investigative teams going there and wanting to examine? No, because every country would have said, oh, this is a matter of our national sovereignty and this, that, and the other. Would we have said, oh, this is a virus that has come out through some lab leak or some nefarious means or something or the other? No. So some of this hyperbole that's being talked about is really, honestly, more political than scientific. Do we know definitively what the source of the virus is? No, we don't. Do we have a reasonable guess that this is natural? Yes, in a statistical sense. What do I mean in a statistical sense? This is the sort of stuff that's happening all the time in nature. Because viruses have so much variation and because host species live cheek by jowl with other species, there'll always be at some frequency variants that will spread from one species into another species and then from another to another and so on. Do we know exactly how this process happened for this particular virus? No, we don't. Do we have any really, really strong reasons for believing that this is not a natural phenomenon? No. So what is my response to this? We should keep investigating. It's most likely that it's what keeps happening. And therefore, that's my opinion about the origin of the COVID-19 virus. It's not something that we should get greatly exercised about.
Yeah. So, Satyajit, it was really great. It's exciting to listen to you after so long, and actually it went 1.5 hours and people are still listening. It's great. That was the power.
I'm astonished that there is still 40 people online.
So people enjoy it. That's why they kept on listening to it. And we had, I think, quite an interactive session. We had quite some questions, and you have addressed all of them. So thank you so much. Thank you so much for all the participants. And thank you so much for the Jyoti Bharati Institute and Professor Dilip Bora, the person that introduced. And he is also, he is not from science background. He is actually an Assamese literature professor in Guwahati University. But he is quite open and he encouraged to organize such lecture series. So I gave my heartiest thank to him as well. But thanks to Satyajit once again. And
Thank you all very much.
Yeah, and we believe we can continue keep doing these kinds of discussions and lectures. Thank you all.
Thank you.
Thank you.
Thank you, and bye-bye.
Thank you.
Bye.
Thank you, sir.
Thank
No.
you, sir. Thank you. Thank you, sir.